Basic Disaster Life Support Course Presentation 3.0. Session 4, Lesson 7, Public Health and Population Health in Disasters. Learning objectives. We will discuss emergency public health response actions that can be implemented in a disaster. Explain the rationale for a function and access-based definition to address all individuals who may be more vulnerable to adverse health effects in a disaster or public health emergency. Describe pediatric vulnerabilities and challenges that need to be addressed in all hazards, disaster preparedness, and response planning. We will discuss women's health issues that need to be addressed in all hazards, disaster preparedness, and response planning. Discuss the potential impact of disasters on individuals with chronic illnesses. Discuss mental and behavioral health consequences for children and adults affected by a disaster or public health emergency. The Institute of Medicine definition of public health systems can be found and reviewed on page 2 to 3 of the BDLS 3.0 course manual. The role of the public health system is to protect the nation against injury, disease, and a myriad of environmental and occupational hazards. The distinct difference between emergency care and public health is that public health focuses its efforts on the population as a whole. The public health workforce is made up of a variety of skill sets, educational backgrounds, and experience, from specialty or specially trained nurses to epidemiologists, to postdoctoral researchers, to lab technicians and social workers. A large-scale disaster or a public health emergency may disrupt and impact important components of a community, including damage to the public health infrastructure, widespread displacement of population affected, disruption of normal health and medical services, and destroying or disrupting access to key resources. It is critical that during times of a large-scale disaster or public health emergency, that a public health system and emergency care system be integrated and working collaboratively. The scope and scale of disasters may significantly exceed resources available for individual care. Large-scale disasters can readily become public health emergencies. These are defined broadly as any event that significantly threatens the health or safety of the public. It is important at this stage for every disaster responder to have an understanding of public health and how we transition our thinking from treating an individual taking care of an entire population in order to provide the greatest good for the greatest number of people. This is in contrast to the traditional medical model of a physician having an independent relationship with each patient and providing all the care the patient needs, regardless of effects on availability of these resources to others. For example, a physician must make the difficult transition from a physician-patient relationship to a physician-population relationship. This is a partial list of the functions of public health during a disaster. We will not cover all these in this lecture, nor read through all them right now. However, it is important that you get a sense of the essential role that public health plays in preparedness, response, and recovery of disasters. Shortly, we will highlight a few of the key functions of which every disaster responder should be aware. Public health surveillance and epidemiologic investigations are directed to the systematic, ongoing assessment of the health of the community. In some cases, an epidemiologist may suspect an outbreak by noticing unusual patterns or clusters of a disease in routine surveillance data. Public health surveillance systems identify new health concerns, manage public information, and measure the effectiveness of ongoing interventions. In a disaster or public health emergency, health assessment and monitoring programs increase dramatically. After surveillance identifies a problem, an investigation begins. These are comprehensive and involve a multidisciplinary team, including experts in clinical medicine, epidemiology, infection control, environmental health, microbiology, behavioral science, biostatistics, and health education. Interviews provide epidemiologists with crucial data needed to map the spread of an outbreak. For example, source of the outbreak, mode of transmission, etc. Through interviews and detective work, epidemiologists may identify the source of the outbreak, the first patient with a disease, the index case, mechanism of spread and possible control, morbidity, and mortality. It is important to complete a rapid needs assessment to determine the nature and scale of the disaster. Identifying the extent of the population immediate needs, as well as the status of the healthcare infrastructure are vital. This will greatly assist in determining the impact on essential human services. In a major disaster or public health emergency, states have authority to exert reasonable control over citizens to directly secure and promote the welfare of the state and its people. They must balance individual rights and freedoms with the common welfare. Classically, there were two major ways that public health may exert power over individual freedom: quarantine and isolation. The goal of these is to decrease exposure and spread of contagious diseases. With disasters involving infectious disease, outbreaks, or other public health emergencies, public health agencies that usually oversee ESF-8 may actually take an overall leadership role in the incident command structure. ESF-8 is public health and medical services, public health, medical, mental health services, and mass fatality management. ESF-6 is mass care, emergency assistance, housing, and human services, mass care, emergency assistance, disaster housing, and human services. Public health plays a supporting role in the provision of services to the affected masses. The primary agency that helps coordinate mass care and sheltering in the United States is the American Red Cross. However, public health may play several roles in this area, such as disease surveillance and core public health functions. This involves providing sheltering of displaced persons, distribution of clean water and food, provision of emergency first aid, and distribution of emergency relief items. In addition, they may be involved in assessing the needs of those with functional and access needs, vulnerable patients, and those with chronic medical conditions, in many cases, providing the services needed. Sheltering is an essential element of disaster response and recovery, a role largely assumed by public health agencies. Shelters are not without their own pitfalls. However, the combination of crowding, limited resources, and a high-stress environment leads to many problems in shelters, most notably outbreaks of disease, especially GI and respiratory illnesses, interpersonal violence, and worsening of chronic and mental illness. Assist emergency managers and shelter planners in understanding the requirements related to sheltering children and adults with functional needs in general population shelters. Lodging and shelter. Sleeping and bathing facilities with adequate privacy are needed. Women should feel comfortable bathing, breastfeeding, and caring for their families. Pharmaceuticals. People would need access to medications that may have been lost in a disaster, including birth control, pills, and supplies. Sanitation. Adequate sanitation is critical to good health. Hygiene supplies. Disasters do not stop menstrual cycles. Appropriate supplies must be available. Pregnancy management. Pregnant women have many special needs, from obstetric care to special diets and medication. They may experience increased levels of stress due to concern over their unborn child. Safety and security. Increased risk of physical and mental abuse, as well as sexual assault. Now we will transition from public health to population health. An important concept to remember is that disasters do not affect all people equally. There are certain groups of people that are more vulnerable to the effects of a disaster. The major groups are infants and children, the elderly, women, those with chronic diseases, including mental health issues, and people with functional or access needs. It is essential to plan for the needs of these populations, as they each have different needs when it comes to post-disaster medical care, support services, and sheltering. Disasters do not discriminate by age. Children and infants are uniquely vulnerable to the effects of disasters because of multiple factors, from anatomic, physiologic, to developmental. At the present time, few communities have plans in place to respond to the special needs of pediatric casualties of a disaster. Every disaster responder must have a working knowledge of the care and support of pediatric patients, even if the care provider only takes care of adults in his or her usual job. Pediatric patients have unique anatomic, physiologic, developmental, behavioral, and familial vulnerabilities that make them prone to effects of disasters. Examples of these are below. Children are more vulnerable to toxic exposures, especially with exposure to agents heavier than air, such as sarin or chlorine. Agents accumulate close to the ground where children live. High body surface area, increased area of skin for absorption of toxins. Rapidly developing brain and nervous systems are more easily damaged. High respiratory rate, minute ventilation, results in increased intake of gases. Children are more susceptible to trauma and burns. Poor understanding of the situation and instruction from adults, along with poorer coordination, make children more likely to get injured. Their more flexible skeletal system enables them to have serious internal injuries with minimal external damage. Children have low tolerance to blood loss and shock, and they compensate well, so evidence of early shock may be missed by providers. Children have a higher risk of infection. They have immature immune systems, especially younger children who do not have all of the vaccinations. They are not aware of the importance of sanitation and hand washing. Children are very prone to hypothermia, as well as heat loss, heat illnesses. They have thin skin and limited subcutaneous tissue. They have greater body surface area. They lack knowledge and behavior traits to get out of the environment, change clothes, and ask for help. For a variety of reasons, many providers are uncomfortable taking care of children, especially in the very stressful environment following a disaster. If all else fails, communicate and interact with the child as if he or she were your own child. Speak to and ask children questions. Ask questions of children who are verbal. If parents are available, include them in all aspects of evaluation and treatment. Parents will likely be afraid and possibly feel guilty or angry. They can be an asset in calming the child, encouraging participation in care, and giving background on the child's health issues and medications. When dealing with pediatrics, you must simultaneously provide clinical care as well as emotional and mental support. Pediatric patients require specific doses of medications and special sets of supplies and equipment for proper care. Many references are available to help with dosing. Planning should include stocks of supplies for mass pediatric casualties. It is essential to keep families together if all possible. If children are separated from their families, reuniting them is high priority. Sheltering children and their families require significant forethought and planning. Children of various ages have various and special needs. Consider that infants and toddlers will require special food, diapers, and wipes. Some will not be able to safely sleep in cots and will require cribs or bassinets. Children are particularly vulnerable to violence and exploitation in the crowded environment of the shelters as well. Nationwide, there is a limited access to pediatric health care, especially specialty care and critical care units. How many pediatric ICU beds are available? To where would you transfer your sickest children? Where are the pediatric burn centers? Traditionally, disaster planning has acute disaster-related illness and injuries, and has largely not considered the needs of casualties with pre-existing conditions. This is very short-sighted, as vast majority of older adults have one or multiple chronic medical conditions, many of which demand the close care of a physician, multiple medications, or special equipment to manage. Disasters disrupt the basic infrastructure of health maintenance for many patients with chronic illness, including pharmacies, dialysis centers, oxygen supplies, refrigeration, electric wheelchairs, wheelchair ramps, and many more. Patients with chronic illnesses can be dramatically affected by disasters. The emotional, physical, psychosocial, and environmental effects of the disaster itself can exacerbate chronic illness. Patients can lose equipment that is mandatory for their everyday functioning, such as wheelchairs, canes, walkers, special foods, as well as life-sustaining equipment, oxygen, dialysis supplies, central lines, feeding tubes, ventilators. Patients often present without any of their innumerable daily medications that are required for the maintenance of their often tenuous health. Medical records are often destroyed, and patients and their families may be unable to provide complete histories. There are many issues relating to patients with chronic illnesses that must go into disaster planning. Preparedness should include education of these people to have current list of medications, allergies, and medical history. Each should obtain or be provided medical lead bracelets or identification. If possible, additional commonly needed durable medical equipment, medication, and supplies are beneficial. Ask yourself, where will patients obtain life-sustaining medical supplies, equipment, and services such as dialysis, chemotherapy, radiation, tube feeding, ventilators, specialty beds? How would these patients be evacuated? Where will they go? How will you transport their special equipment? Population with functional or access needs require special assistance with maintaining independence, communication, transportation, supervision, or medical care. These populations each have very different needs. It is important to assess your own community to understand the needs therein. Then you can appropriately plan for the myriad of issues that will come up in a disaster. Special planning is needed for evacuation, sheltering, durable medical equipment, medical devices, medications, transportations, and more. Professionals trained to take care of these populations within your community not only should be involved in the planning process, but also must be utilized in the care and supervision of care after the disaster. Everyone involved in a disaster will have his or her own response to the event, whether that is psychiatric, psychosocial, or behavioral. Responders too are affected. This is normal. Responses can vary, but some symptoms include fear, worry, anger, helplessness, confusion, anger, fatigue, loss of appetite, sleeplessness, and many more. Disasters can induce a range of normal responses, including a sense of apprehension, worry, edginess, and difficulty concentrating on anything other than the source of the threat. Rational and irrational attempts to remove or escape from the threat. There are altruistic behaviors intended to ameliorate the situation. In general, An abnormal response that impairs daily life may occur when symptoms are greater in duration or intensity. When symptoms result in avoidance of certain situations or objects, and if certain patterns of symptoms occur and persist. Emergency responders are susceptible to the same psychological reactions and trauma as everyone else. Responders should be closely monitored for dissociative symptoms of acute stress disorders, as well as for impairment of functioning. Formal critical incident stress debriefing is no longer recommended, since research has failed to demonstrate any consistent benefit and indicates that it may in fact be psychologically harmful to some. Debriefing and sharing stories is still a helpful agent to help manage post-disaster psychological responses. Realistic training and education prior to events can be helpful in building up individual and team resilience to traumatic events and disasters. Question 1. Large-scale disaster and public health emergencies require health professionals to shift their perspective from individual-provider relationship to A, global, B, population, C, workforce, D, personal, E, all of the above. Health. Question number 2. Which of the following is a function of public health during a disaster? There are 5 options on your slide. Which is the best option? Question 3. Disasters disproportionately affect certain vulnerable populations, including all of the following except. 5 options on the slide. Which one is the best suitable? Summary. Disasters require us to change our focus from the needs of the individuals to those of the population as a whole. Integration of public health and emergency care is essential to response and recovery. Certain groups in our communities are especially vulnerable to the effects of disasters and require special planning. Any questions? Thank you.